We are back with another series. Let's revise PYQs. This will benefit you in your upcoming exam. Let's look at the first question from this video. Question 1. The baby had chest retractions, difficulty breathing, and lack of energy. The pediatrician determined that the baby was suffering from respiratory distress syndrome. This condition arises because of the lack of. Your options are. And the correct answer is lecithin. Here's the explanation.
Now this respiratory distress syndrome is also known as hyaline membrane disease, okay, or HMD. Now this hyaline membrane disease or respiratory distress syndrome is the most common cause of respiratory distress in a preterm neonate, okay. So it is much more common in preterm neonates, but it may sometimes happen in term neonates also, especially in infants of diabetic mother, okay, because they have a delayed maturation of surfactant. So the basic defect in respiratory distress syndrome is the lack of mature surfactant, okay. So the lack of adequate amounts of mature surfactant. Is the basic defect that is there, okay, in respiratory distress syndrome. So we need to know a little bit more about this surfactant and why is it important for us and what is the pathophysiology of respiratory distress syndrome, okay. Now starting with the composition of surfactant. One of the most important constituents of surfactant is DPPC, that is the dipalmitoyl phosphatidylcholine or lecithin, okay, phosphatidylcholine or lecithin. That is one of the most important constituents of surfactant, okay. Apart from that, there are some surfactant proteins. Types A, B, C and D, out of which surfactant protein type B is again the most important, okay, right. Apart from that, surfactant also contains cholesterol and cholesterol and its esters, okay, and it also contains phosphatidylglycerol. So these are the constituents of surfactant, and the function of surfactant is to decrease the surface tension of alveoli, okay, to decrease the surface tension.
Question 2. What is the most probable diagnosis for a 3-month-old baby presenting with complaints of deafness, cataract, and patent ductus arteriosus? Your options are. And the correct answer is congenital rubella syndrome. Here's the explanation.
This neonate who had these skin lesions that you can see, okay, and was found to have a systolic murmur. So there are some skin lesions, a systolic murmur and deafness on evaluation. There is a history of fever with rash in the mother, okay. There is a history of fever with rash in the mother during the antenatal period. What is the probable diagnosis? So, fever with rash in the mother during antenatal period. If you are given with that history, you think of a congenital infection. And we know congenital infections are most commonly due to the TORCH group of organisms. That means toxoplasma, others like syphilis, rubella, CMV and herpes, okay. Now, newborn has got these skin lesions. So, what are these skin lesions? So, these skin lesions are nothing but blueberry muffin spots, okay. They are the blueberry muffin spots which are due to, extramedullary hematopoiesis. So, blueberry muffin spots. Okay, these blueberry muffin spots signify that in dermis some extramedullary hematopoiesis is going on. The baby probably has pancytopenia. This murmur, systolic murmur, tells us that the baby has some heart disease, okay, and deafness is also there. So, all these features will point towards a diagnosis of congenital rubella syndrome, okay. So, congenital rubella syndrome, the characteristic features that you have are CDC, that means cataract or other eye manifestations like chorioretinitis, D for deafness, and C for congenital heart diseases. Now, this congenital heart disease can be a patent ductus arteriosus, it can be a ventricular septal defect, or any other congenital heart disease. In addition, the baby can have, hepatosplenomegaly, and there is a history of fever with rash in the mother during pregnancy, and these blueberry muffin spots can be present in the baby, right? So, this typically your diagnosis, friends, here would be congenital rubella syndrome.
Question 3. A baby presented with abdominal pain. On examination, a mass is palpated in the left lumbar region. A barium enema is done, and the image is given below. What is the likely diagnosis? Your options are. And the correct answer is intussusception. Here's the explanation.
So, intussusception is basically when one portion of the alimentary tract, or the GI tract is telescoped into another. Okay, is telescoped into another. Then you call it intussusception. Okay. The most common type is the ileocolic type of intussusception. Ileocolic, where a part of the ileum, terminal ileum, is telescoped into the colon. So, the most common type is the ileocolic type. And this intussusception is the most common cause of intestinal obstruction in children between 5 months to 3 years of age. 5 months to 3 years age. Right? So, the pathophysiology of intussusception. So, intussusception, basically what happens is, there is when new food products are introduced in the diet of the child, there is hypertrophy of these Peyer's patches or the lymphoid cells which are present in the intestine, and they act as a lead point for development of intussusception. So, what happens is, there is swollen Peyer's patches or the lymphoid aggregates in response to GI infection or introduction of new food items. GI infection or introduction of new food items. Okay, and they act as lead points. Okay. And usually what you get in intussusception is, the child is like really in distress and it is a very painful condition. So, pain abdomen is there, and sometimes you can get red currant jelly stools. So, there can be blood in the stool. So, intermittent colicky pain with red currant stools can be there. So, in intussusception, you can get, pain abdomen can be there, intermittent colicky, severe pain abdomen, a sausage shaped abdominal mass can be there, the child can have vomiting and all, and there can be red currant jelly stool. So, blood in the stool can also be there. Okay. So, diagnosis can be done either by ultrasound. Okay, ultrasound is a very good modality, and ultrasound has a good sensitivity. So, diagnosis can be done by ultrasound, which has a good sensitivity for picking up intussusception. Right. And barium enema can show this claw sign. You can see this claw like. So, barium enema can show your claw sign, or there can be one coiled spring sign in intussusception. Okay.
Question 4. During the anthropometric evaluation, the height for the age of a child is less than -2 SD. This is most likely due to. Your options are. And the correct answer is chronic malnutrition. Here's the explanation.
And the best indicator of chronic malnutrition or long-standing malnutrition is decrease in height for age. That is also known as stunting. Okay, stunting. Right? So, if the height for age again is between -2 to -3 Z-score, or between 70 to or between 85 to 89% of expected, we call it stunting. Stunting.
Question 5. For which disease is the diagnosis made based on the level of chloride in sweat? Your options are. And the correct answer is cystic fibrosis. Here's the explanation.
So what are the diagnostic criteria for cystic fibrosis? One is that the clinical picture or clinical features should be compatible. Okay, clinical features should be characteristic of cystic fibrosis. So clinical features characteristic of CF should be there, like we said, recurrent diarrhea, recurrent pneumonia, steatorrhea. Okay. Then there can be a history of cystic fibrosis in a sibling or a first degree relative. Okay. So history of cystic fibrosis in a sibling, or if there is positive newborn screening test for cystic fibrosis. So many countries do newborn screening for cystic fibrosis, and that is done using IRT or immunoreactive trypsinogen, and that is also often asked. Okay, so positive newborn screening test, screening for CF. Okay, and that is done using IRT or immunoreactive trypsinogen. Immunoreactive trypsinogen. Okay, right? So either of these three we want, either any one of these three plus some investigation findings like, sweat chloride more than 60 millimoles per liter on 2 separate occasions. So elevated sweat chloride. So sweat chloride is a easily doable test. Okay, sweat chloride more than 60 millimoles per liter on 2 or more occasions. Okay. So elevated sweat chloride is one criteria among the investigation criteria. Okay. Or detection of 2 CA, cystic fibrosis causative mutations. So, or 2 mutations detected in the CFTR gene. Okay, CFTR gene. Or abnormal nasal transepithelial potential difference. Okay, abnormal nasal transepithelial potential difference. Okay, transepithelial potential difference. So any one of criteria on the left side and one of criteria on the right side.
Question 6. What is the probable diagnosis for a child who has a fever and a rash that starts on the face, spreads behind the cheeks and buccal mucosa, and then extends to other areas of the body, with the presence of complex spots upon examination? Your options are. And the correct answer is measles. Here's the explanation.
Now moving ahead, the clinical features of measles. So initially there is a prodromal phase where there is presence of fever, conjunctivitis and coryza. The child has a wet kind of a look. Okay, there is fever, conjunctivitis and coryza, right? And there are something known as coplic spots. These are reddish spots with a white center. So these are coplic spots which are present on the inner side of the cheek, on the buccal mucosa. Okay, present on inner cheeks, but they can also be present on conjunctiva and vaginal mucosa. Okay, on conjunctiva as well as vaginal mucosa. Okay, and the rash of measles typically begins from behind the ears and then spreads to the rest of the trunk, downwards to the rest of the body. So rash begins behind ears and spreads to the rest of the body. And there is this maculopapular, the rash is erythematous maculopapular rash, which is confluent at places. And the rash usually appears on day 4 of fever. Okay, on day 4 of fever. And the rash disappears in 7 days in the same progression as it appeared, leaving behind a brownish discoloration. Okay, pigmentation. So the rash fades in 7 days in the same progression as it appeared, leaving behind a brownish pigmentation.
Question 7. In a child presenting with infantile hypertrophic pyloric stenosis, what metabolic abnormality is commonly observed given the presence of recurrent episodes of non-bilious vomiting? Your options are. And the correct answer is hypokalemic alkalosis. Here's the explanation.
So the typical case scenario where you suspect congenital hypertrophic pyloric stenosis is in a baby 2 to 6 weeks age, in a baby 2 to 6 week old baby, usually a male baby, more common males than females, infant with forceful projectile non-bilious vomiting, with forceful projectile non-bilious vomiting. And there may be a olive shaped mass palpable in the abdomen of the baby with visible peristalsis and an olive shaped mass palpable in the abdomen of baby, upper abdomen of the baby. So that is the typical case scenario where we are going to suspect a diagnosis of congenital hypertrophic pyloric stenosis. Okay. Examination findings that you will get visible peristalsis from the left to right side, okay, like this. So visible peristalsis in the upper abdomen, from the left to right side. What else? You can get a visible and palpable olive shaped mass, which is the hypertrophic pylorus, okay. Visible and palpable olive shaped mass which is palpable in the mid gastric area, best palpable just after a bout of vomiting, okay, in the mid gastric area, easiest to palpate after an episode of vomiting. Okay, these babies can also have dehydration. And maternal intake of azithromycin or erythromycin are risk factors for their development of this congenital hypertrophic pyloric stenosis. So investigation findings, what you will get in blood investigations, you can get hypokalemic metabolic alkalosis. Why metabolic alkalosis? Because the hydrochloric acid from the stomach is getting coming out with the vomiting. Okay. So hypokalemic metabolic alkalosis with paradoxical aciduria is what is typically found. With paradoxical aciduria. Okay.
Question 8. What is the probable diagnosis for a child who exhibits generalized swelling and is diagnosed with high cholesterol levels, as well as protein 3+ and fat bodies observed in urine analysis? Your options are. And the correct answer is nephrotic syndrome. Here's the explanation.
Now the clinical features of nephrotic syndrome, as we mentioned, there is edema. So this edema usually begins as puffiness around the eyes. So usually begins as periorbital puffiness or puffiness around the eyes. Okay. And it gradually extends to have pedal edema. So there is pitting pedal edema. Okay, pitting pedal edema is there. Then there is generalized edema or anasarca. Okay, generalized edema and anasarca. Anasarca means there is fluid in the other cavities as well, like pleural effusion and peritoneal collection. Okay, pleural effusion and peritoneal collection. Now there are some hypotheses which have been proposed for edema in nephrotic syndrome. They are the underfill hypothesis and the overfill hypothesis, and that is a controversial arena. Some believe that there is decrease in the intravascular volume which is contributing to the activation of the renin-angiotensin mechanism, and there is increased fluid retention, and some schools of thought believe that there is salt and water retention to begin with. That is the primary thing. So whatever it is, but generalized edema and massive edema is what you get in nephrotic syndrome. Okay, the children from a distance only you can identify they are so swollen and plump. Okay. Now there is increased susceptibility to infections. This is basically due to the loss of complement factors and immunoglobulins in the urine. There is massive proteinuria we said. So there is loss of immunoglobulins and complement factors in the urine which give rise to it. Complement factors in urine. Okay. And the infection is mainly due to encapsulated bacteria. Okay. So mainly due to encapsulated bacteria like Streptococcus pneumoniae. Encapsulated bacteria like Streptococcus pneumoniae. Right? Okay. And cellulitis and spontaneous bacterial peritonitis is quite common. Cellulitis, that is infection of the skin and subcutaneous tissue, and spontaneous bacterial peritonitis, that is the infection of the peritoneal collection, are quite common in these children. Okay. There is a hypercoagulability. So this is due to the loss of proteins S and antithrombin 3 in the urine. So due to the loss of protein S and antithrombin 3 in the urine, okay, and there is also hemoconcentration and stasis. Hemoconcentration because a lot of fluid goes to the extravascular volume, and there is stasis, okay, because of the hemoconcentration, sluggish blood flow is there, right. So this contributes to a hypercoagulable state, and there is increased risk of thrombi formation, deep vein thrombosis also, and thrombosis of multiple organs, strokes, okay. So increased risk of thrombosis is there in these children, right. Now investigations in a child with nephrotic syndrome. To begin with, we will do a urine. So urine will show a massive proteinuria. The UPUC will be greater than equal to 2, or urine protein by dipstick 3+ or more by dipstick, okay. And you can get hyaline casts can be there, okay. And you can also get hyaline casts in the urine. If you do a serum albumin level, it is usually less than 2.5 mg per dl. Increased levels of lipids, triglycerides and cholesterol are there. Increased serum, triglycerides and cholesterol, and sometimes in your history frothy urine is also mentioned. So there is frothy urine, and the stool can have oval fat bodies because of the excess lipid, okay, in the body. So that can also be there.
Question 9. What is the diagnosis for a 4-year-old boy who has muscle weakness, difficulty climbing stairs, and getting up from the floor, with muscle biopsy showing small muscle fibrils and absence of dystrophin? Please choose the correct option from the given choices. Your options are, and the correct answer is Duchenne muscular dystrophy. Here's the explanation.
Now moving ahead to some clinical features of Duchenne and Becker muscular dystrophy. Now these children are usually going to present the symptoms are going to be progressive, proximal muscle weakness. So progressive proximal muscle weakness, okay, weakness involving the thigh muscles, the arm muscles, so proximal muscle weakness of limbs. So progressive proximal muscle weakness is what they usually present with, and because of that there may be a history of delayed walking or frequent falls while walking, okay, frequent falls while walking. There may be a waddling kind of a gait, okay. So waddling kind of a gait because of again this proximal muscle weakness. So there can be a waddling or duck-like gait. Early weakness of neck flexors, so difficulty in raising the head and all also can be present, okay. And importantly, a family history is many a times available. So family history of multiple siblings affected, or maternal uncles, that means the brothers of mother may be affected, mother being a carrier, because it is X-linked recessive inheritance, okay. So family history of multiple siblings or maternal uncles being affected, right. So these are typically the symptoms which are there, and sometimes they develop contractures. Once they become so slowly they are going to become non-ambulatory and wheelchair bound. And once they become non-ambulatory, then they have many more features like, respiratory compromise is going to be there, bulbar dysfunction can happen, okay, and a lot of cardiac issues can come up and so on. So after the loss of ambulation, as we mentioned, what all can happen? There can be kyphoscoliosis. There can even be weakness of upper limbs. Okay, weakness of upper limbs can be there. Bulbar weakness can be there. Bulbar weakness. Weakness of intercostal muscles and diaphragmatic weakness, and so respiratory compromise. Weakness of intercostal muscles and diaphragm. Okay. And there can be this cardiac abnormality, cardiomyopathy and arrhythmias can be there. Cardiomyopathy and arrhythmias. Right? So what all are the clinical signs which you can see in a child with DMD or BMD? So DMD or Duchenne or Becker muscular dystrophy again is more commonly seen in boys, obviously because it has X-linked recessive inheritance, okay. So it is more commonly seen in boys, rarely the females are affected, okay, but sometimes they may be affected when there is unfavorable lionization or in Turner syndrome, single X chromosome and so on. Now, if you examine these children, you will see a pseudo hypertrophy of the calf muscles. So if you look at the calf muscles from behind, they will appear to be like hypertrophied like this, okay. So this is the foot. So this area is the pseudo hypertrophy of the calf muscles. It also gives an inverted bottle appearance. So as if, a water bottle, you have inverted it like this. Okay. So this is called pseudo hypertrophy of calf muscles. Pseudo hypertrophy of calf muscles, giving a inverted bottle appearance, okay, inverted bottle appearance, right? What else? Now in these children, one more sign can be seen, that is called valley sign. So we will see again in the image based section, but if you ask these children to do their hands like this and look from behind, what will happen? You will see a valley or a depression, okay, in the infraaxillary fold region. So in this depression, there is the pseudo-hypertrophic deltoid and the infraspinatus muscles, and in between them you can find a groove-like area. So that is called valley sign, okay. So valley sign is a groove-like depressed area in between the hyper or pseudo-hypertrophic deltoid and the infraspinatus muscles, okay. So valley sign can be positive. You can also get Gowers sign positive. So what is Gowers sign? So Gowers sign, we know if you ask a child with, proximal muscle weakness like in Duchenne or Becker muscular dystrophy to get up from sitting position. So you make the child sit on the ground, ask him to get up, okay. Then what will he do? He will first take the help of his hands and put them on the ground. Then put his hands to the legs, put his hands to his knees, and slowly taking support of himself, the child is going to stand up. So that is Gowers sign. That is not specific of Duchenne or Becker muscular dystrophy. It can be seen in any child who has proximal muscle weakness. Okay. It can even be seen in juvenile dermatomyositis. But it is one of the features which is commonly asked in your exams, and it is typically seen in this Duchenne and Becker muscular dystrophy. So Gowers sign. Plus, you can also get an exaggerated lumbar lordosis in these children. Okay. A waddling kind of a gait can be there. Okay. Duck-like waddling gait and an exaggerated lumbar lordosis. These children can have varying degrees of intellectual disability also. So sometimes, mostly they have a normal intelligence, but they can have varying degrees of intellectual disability. Okay.
Question 10. What is the diagnosis for a child who is brought to the hospital with respiratory distress and biphasic stridor, as indicated by the radiograph provided? Your options are, and the correct answer is acute laryngotracheobronchitis. Here's the explanation.
A similar disorder where a child will present with stridor and some breathing difficulty is croup or acute laryngotracheobronchitis. Okay. So this acute laryngotracheobronchitis or LTB is also known as croup. Okay. And the most common organism responsible for croup is parainfluenza virus. Parainfluenza virus. But it can also be caused by other viruses like, influenza virus, adenovirus and so on. but the most common organism responsible is parainfluenza virus. So croup is a viral illness. So the clinical features of croup, the child is not so sick as in acute epiglottitis. So the child will present with, low grade fever, coryza, malaise. So features of a viral disease. Okay, and there can be some stridor, which may be present only on crying, or sometimes in severe cases may be present at rest or at rest. There can be some breathing difficulty can be there. Okay, breathing difficulty may be there. Right? Hypoxia may or may not be present. Hypoxia may or may not be present depending on the severity. Okay. So that is the typical case scenario where we suspect croup. And for the diagnosis of croup, if you do a straight X-ray of the oropharynx or the face and the neck AP view, okay, X-ray AP view. So for the diagnosis of croup, we do a straight X-ray AP view of the face and the neck. So the airways will show you a narrowing, okay. So X-ray AP view will show you something known as steeple sign, okay, steeple sign. So the airway will appear just like the steeple of a church. So, just like this, the airway is there and there is narrowing at the top. So there is narrowing at the top like this. Okay. So it is the steeple sign that you see. Okay. On the X-ray in croup. So thumb sign in acute epiglottitis, steeple sign in croup.
Question 11. What is the vessel responsible for returning deoxygenated blood back to the placenta in fetal circulation? Your options are, and the correct answer is umbilical artery. Here's the explanation.
Finally, two branches will come from the aorta, which are the umbilical arteries, which will go back to the placenta for oxygenation. So finally, there will be two umbilical arteries, which will go back to the placenta for oxygenation. So these two are the umbilical arteries which contain deoxygenated blood. Okay, they are the ones containing deoxygenated blood and they will go back to the placenta for oxygenation.
Question 12. A 1-day-old neonate has not passed urine since birth. What is the next step in management? Your options are, and the correct answer is continue breastfeeding and observe. Here's the explanation.
How to assess the adequacy? How to assess whether breast milk is adequate for the baby? How to assess whether breast milk is adequate for the baby? Okay, a very pertinent question, practically also and for your MCQs also. Adequate for the baby. So if the breast milk is adequate for the baby, the baby is going to, after feeding, the baby will sleep for 1 to 2 hours. So baby sleeps for 1 to 2 hours after a feed. What else? The baby should pass urine at least 6 to 8 times a day. So baby should pass urine at least 6 to 8 times a day. And the baby should be gaining weight. If the feeding is adequate, weight gain will be there.
Question 13. What is the most probable diagnosis for a 1-month-old baby who has jaundice, clay-colored stools, conjugated hyperbilirubinemia, and periductal proliferation observed in a liver biopsy? Your options are, and the correct answer is biliary atresia. Here's the explanation.
Extrahepatic biliary atresia. So EHBA is one of the most important causes of conjugated hyperbilirubinemia, obstructive causes leading to conjugated hyperbilirubinemia in neonates or infants. Okay, so it will present in usually neonatal period with severe jaundice, with progressively increasing severe cholestatic jaundice or conjugated hyperbilirubinemia. Severe cholestatic jaundice. And you can get a history of, high colored urine and pale or clay colored stools. Okay. So high colored urine, that means very dark yellow urine. So high colored urine and pale or clay colored stools may be present. Okay. And for the screening of, whether biliary atresia is present or not, a test which is often used is HIDA scan or hepatic scintigraphy. So hepatic scintigraphy or HIDA scan is used as a screening tool. HIDA scan is used as a screening tool. Okay, screening tool. So for screening, for whether a neonate has got extrahepatic biliary atresia or not, hepatic scintigraphy or HIDA scan is often used. So hepatic scintigraphy or HIDA scan is used as a screening tool. Okay, HIDA scan is used as a screening test. So what you do in this test is you will inject a liver-specific radioisonucleotide or radioisotope in the blood, and what will happen is it will get concentrated in the liver, and from liver through the biliary tract it should get excreted and go to the intestine. If you detect no radioactive activity or radioisotopic activity in the intestine, that means there is some obstruction to the drainage of bile from the liver to the intestine. So that will give you the diagnosis of biliary atresia. Okay, and the treatment of choice is surgery. Kasai procedure or hepatic portoenterostomy, where you make a shunt between the liver and the intestine. Okay, Kasai procedure. And Kasai procedure has got best outcome or better outcome if done before the child turns 8 weeks age. Okay, so better outcome if done at less than 8 weeks age. If you do it beyond 8 weeks age, then it has got a poor outcome, right? So that is about biliary atresia. And remember, in fact, this extrahepatic biliary atresia is the most common cause of liver transplantation in children as well.
Question 14. What should be the next course of action in the case of a 2-month-old baby who was born to a mother infected with HIV and is experiencing repeated episodes of diarrhea? Your options are, and the correct answer is dried spot sample for HIV DNA PCR. Here's the explanation.
So how do you diagnose HIV in infants? So nowadays, diagnosis of infants can be done by, nucleic acid amplification test at birth. So you can do NAT or nucleic acid amplification testing. Nucleic acid amplification testing. It is ideally to be done at birth or within 2 days of birth. Okay, at birth. Within 2 days. And start nevirapine with or without zidovudin depending on whether baby is low risk or high risk. Okay, start nevirapine with or without zidovudin depending on whether baby is high risk or not. Okay, if the NAT result comes to be positive, okay, if it is positive, then you repeat NAT, and if that is also positive, then HIV is confirmed in the baby and you start proper antiretroviral treatment. Okay, so if the NAT is negative, then you do HIV-1 DNA PCR on DBS at 6 weeks. Again, if it is positive, you do whole blood DNA PCR. Again, it is positive, reconfirm and then start ART. Whole blood DNA PCR, which is also positive, then you repeat. Still it is positive, you start ART. If it is negative at 6 weeks, then you repeat at 9 months. Okay, repeat at 9 months. And usually the definitive diagnosis is done around 18 months age or at least 3 months after stopping breastfeed. So definitive diagnosis at 18 months or at least 3 months after stopping breastfeed. Okay. Now, apart from, this nevirapine and zidovudin, you also have to start co-trimoxazole prophylaxis for the babies, and it needs to be continued if HIV comes positive, or unless HIV infection has been completely ruled out, you continue co-trimoxazole prophylaxis as well.
Question 15. What is the recommended treatment for a male child who is experiencing joint pain and abdominal pain with the presence of palpable purpura on the lower limbs? The patient also has a previous history of upper respiratory tract infection preceding the current symptoms. Your options are, and the correct answer is observation. Here's the explanation.
Henoch-Schönlein purpura. So Henoch-Schönlein purpura is a small vessel vasculitis which is mainly seen in children. It has a diagnostic criteria. What is the diagnostic criteria? Let us see. So there is palpable purpura. Okay, in Henoch-Schönlein purpura there is palpable purpura with one or more of, okay, so with one or more of the following. So what all? So there can be diffuse abdominal pain, okay, diffuse abdominal pain, arthritis or arthralgia, okay, arthritis or arthralgia, right? Or there can be renal involvement in any form. So there can be acute kidney injury, or there can be, some proteinuria, hematuria and so on. So renal involvement can be there, okay, or any biopsy showing IgA deposition. So any biopsy showing IgA deposition. So it can be kidney biopsy, it can be skin biopsy. So IgA deposition in any biopsy. So that is the diagnostic criteria for Henoch-Schönlein purpura, right? So it is a clinical diagnosis mainly, okay? And glomerulonephritis is seen in almost 1/3 of cases, okay? Seen in almost 1/3 of cases of Henoch-Schönlein purpura. So that is why it is very important to keep these children under regular follow-up and screen them, their urinary samples, to see if there is any evidence like active sediments, hematuria, proteinuria, if they are developing any evidence of glomerulonephritis or not. Okay, hypertension can be there. Remember, even though it is purpura, but thrombocytopenia is absent in Henoch-Schönlein purpura. So the purpura here is not because of thrombocytopenia, but it is because of the vasculitis, the inflammation, the leukocytic cytoplastic vasculitis involving the small vessels. Right? Now, what is the treatment? Recently, there was a question in your NEET pattern exam on the treatment or drug of choice for Henoch-Schönlein purpura. So most of the cases are self-limiting and do not require any treatment. Okay, so most of the cases are self-limiting and do not require any treatment. Okay, but for the severe cases, what you can do is, for severe cases, corticosteroids can be used. Okay, corticosteroids like prednisolone can be used for severe cases.
Don't forget to like and subscribe if you found the video interesting. See you in the next one.